Hello, welcome to this Stony Brook live streams. My name is Dr. Pat Coyle. I'm a neurologist at Stony Brook and I direct Stony Brook's MS Comprehensive Care Center. In the last year, the neurology and neurosurgery services at Stony Brook had the delight of being ranked in the top 4% of hospital programs in the entire United States. In this live streams, we're going to be focusing on the MS Multiple Sclerosis program. And let me introduce my panel. First, Pat Melville, our physician extender nurse practitioner. She holds leadership positions in the International Organization of MS Nurses and is the president-elect of the certifying board of that organization. Welcome, Pat. Secondly, Nancy McClinsky, who is a fellowship-trained MS neurologist with particular expertise in cognitive issues and the use of cannabinoids in MS. Welcome, Nancy.
Thank you.
And finally, Olga Suritsina, a fellowship-trained MS neurologist with a particular interest in the gut microbiome. Now, we're going to be covering various topics in the next 45 minutes, general topics on MS, diagnostic issues, treatment issues, and MS in the COVID era. And please send us your pressing questions as well. But let me start off by asking Pat, exactly what is MS and who is affected by this disease?
Well, thank you. And so MS is the most common acquired neurological disease affecting young adults. It's a disease in which the immune system mistakenly attacks and ultimately damages the myelin, which is a fatty substance that protects and insulates the nerves. The people that are most commonly affected with MS are young adults, typically diagnosed between the ages of 15 and 50, although it can occur in pediatric populations, very rare, thankfully, and people even older than the age of 60 can be diagnosed. It's estimated that there are over 1 million people in the United States alone with MS and probably 2.5 million worldwide.
Okay, there are different types of MS. I've heard it called clinical phenotypes. Nancy, what exactly are the different types of MS?
Yes, hi. So there are 3 main types of MS. The first one is the relapsing remitting form, or also referred to as the relapsing form of MS. This is encompasses about 85% of patients who are initially diagnosed with MS. Basically, there's a first episode of neurologic symptoms, and then eventually those symptoms improve, either partially or fully, and then perhaps another set of symptoms occur. And this is how we refer to the relapse and the remission of the disease. The second type of MS is secondary progressive MS, and this generally follows relapsing remitting MS. This is when there's a less active phase of MS, and we see a more slow progression of disability. The third type is primary progressive MS, and this is the type of MS that initially begins with neurologic symptoms, and then there are no particular remissions. There's just a continued progression of disability, potentially a very slow progression of disability over time. There is another form of secondary progressive MS referred to as a relapsing secondary process, but this we can kind of include in the secondary progressive category. So essentially we have a progression of disease, and then superimposed on that, there can be relapses.
Okay, Olga, a question for you. What exactly is the cause of MS? What starts MS? Why does it occur?
So thank you for the question. The cause of MS is now unknown. Scientists work in several areas which they think contribute to MS. One of them is immunologic. it is thought that immune system acts abnormally, which can lead to MS. Then there can also another factor, which is epidemiologic. For example, it is known that people far from equator are more common to have MS. For example, vitamin D deficiency can increase the risk of MS too. There can be also genetic factor playing in, but it is not genetic disease. But it is known that, for example, in families of twins, if one twin has MS, another twin can have MS in 1 out of 4 cases. So a lot of factors can contribute into MS. So there is no definite cause of MS at this point.
Okay. The prototypic MS patient I always think of is a young woman of childbearing age. And it really does come up with regard to whether an individual has MS, whether their children are going to be at increased risk. Olga touched on this, but Pat, I think it's a very important question. Do people inherit MS? How do you speak to our patients?
Right. So strictly speaking, no. As Dr. Strinskaya just mentioned, there are many genes that are being looked at and being isolated that may increase somebody's susceptibility. But it's strictly speaking, it's not an inherited disease, but it can run in families. The risk of a woman passing along MS to her child is about 2 to 3% if there's a sibling or parent with MS. But as Dr. Strinskaya mentioned, interestingly enough, for identical twins, the risk is about 1 in 4 if one of the twins does have MS.
So that's certainly not very high. So genetics is not the key issue. And I also sometimes mention that there's a slightly higher risk when a sib has MS than when the parent has MS, really suggesting environmental factors may somewhat trump genetics. Nancy, let's turn to diagnostic issues. How do we diagnose MS?
Yeah, so there's not one single diagnostic test used to diagnose MS. It's usually a combination of different aspects. So, for example, a patient may present with certain neurologic symptoms that may be suggestive of MS. So when a patient is seen by their neurologist, they would have a full neurologic exam looking for signs of neurologic dysfunction. Then the patient will likely have an MRI of the brain, oftentimes the spinal cord as well, looking for characteristic lesions that would be suggestive of MS. In addition to that, there are other things we can do to more discreetly determine a diagnosis. So, for example, spinal fluid analysis can be helpful in the diagnosis. There are also ophthalmologic evaluations that can screen for certain findings in MS. And obviously, we would want to rule out other mimics of MS through blood work and that sort of thing.
Okay. So let me turn to Olga to ask her, are there formal diagnostic criteria for MS? And if so, do you use them? And are they being widely used in the United States? So tell me about the formal diagnostic criteria for MS.
So as Dr. Maklinsky said, there is no one test which can determine if patient has MS. Doctor usually uses several strategies to find out if person has MS. Physician needs to find at least 2 areas in the central nervous system which had the damage. It's either a spinal cord, optic nerve, or the brain. Then there should be evidence that the damage has occurred like separation in time, and then other diagnosis needs to be excluded. The current criteria which I used are 2017 McDonald's criteria. They help. They include MRI to see if the patient had another silent attack, which is not present right now, but can say that there was a prior attack in the past. These criteria also include oligoclonal bands, so spinal fluid can be used in helping to determine of MS diagnosis.
So I think this is a very important point. We do have formal diagnostic criteria. As Olga pointed out, they're the 2017 revised McDonald diagnostic criteria. They are not being commonly used in the United States, and I think that's a big error. I think they should be used. And I think that anybody should be able to ask their physician, do I meet criteria by the 2017 revised McDonald criteria for MS? They actually specify specific criteria to make a diagnosis of that unusual form of MS called primary progressive, which is only about 10 to 15%. And interestingly enough, shows an equal sex ratio, 50-50 split, compared to the typical female predominance, that's 3-to-1 overall in MS. So I think it's very important to use those formal diagnostic criteria. Pat, this brings us to, the laboratory workup of MS. It has been said that MS is a clinical diagnosis, okay? But I can't imagine in this era not doing laboratory testing to make the diagnosis. What do you recommend doing to make a diagnosis of MS, Pat?
Yes. So as my colleagues mentioned, making a diagnosis of MS can be very complicated, and you really need to be evaluated by a clinician who is familiar with all of the criteria. I oftentimes say to patients that the diagnosis of MS is almost like putting together the pieces of a puzzle, and all of those puzzle pieces have to fit. There has to be a certain clinical presentation, and then there has to be laboratory supported evidence. And again, all of those puzzle pieces need to fit together. There can be certain conditions that can mimic MS. So, for example, blood work that may be done would include checking for vitamin deficiencies, such as, for example, a vitamin B12 deficiency, checking for other neurological disorders, checking for rheumatological diseases, checking for infections. These are all things that need to be ruled out. Living here on Long Island, we really always check for the presence of Lyme disease. And as Dr. McClinsky mentioned, a spinal tap or a lumbar puncture can be critical in helping us to make that diagnosis. Again, there are things that are going to be ruled out looking at the spinal fluid, such as infections and viruses, once again, Lyme disease. And we're also going to be looking for the presence of certain proteins that we know are abnormal in the fluid, the spinal fluid of patients with MS. Other laboratory testing that might be done might include an ophthalmological evaluation, something called OCT, or optical coherence tomography. This is a test in which an ophthalmologist is looking in the back of the eye, and they can look at the retinal nerve fiber layer. And this is another tool that can be helpful to us when we're making that diagnosis and putting that puzzle together.
That's a really important point. That OCT, that optical coherence tomography, looks at part of the central nervous system because the optic nerve is part of the CNS with none of the myelin sheath. So it's the pure axons and neurons. And there's a recent study that indicated that doing OCT early and looking at the pure neuron layer, it's called the ganglion cell interplexiform layer, was able to predict disability 10 years later. So I think that may be a really helpful thing to do. Nancy, I've heard that the MRI is probably the main laboratory test that we use for MS. What can the MRI tell us about MS, and how would you explain it to MS individuals? What are we looking for when we look at an MRI scan?
So when we look at an MRI, we're looking at areas where the myelin has been damaged. And that can be seen as either a bright white spot or a dark spot, depending on the MRI sequence that we're looking at. So they can be seen in certain areas of the brain that are more characteristic of what we see with MS. So it gives us an idea of how many lesions that we're seeing and their location to give us that much more information about whether this fits with a diagnosis of MS. The other thing that we use MRIs for is to track the progress of the disease. So when you're first diagnosed, you may, once you're started on medication, receive another MRI, within 6 to 12 months, and then we take a look to see if more lesions have developed in that time period. Sometimes we use gadolinium or a contrast dye to give us more information about the lesions and whether or not they have recently formed. So the contrast dye is attracted to areas of active inflammation, and if lesions have formed within the last 2 weeks up to sometimes up to 2 months, we can see those areas light up on the MRI.
Great. Olga, we have a question from Carly in the audience. When we're making a diagnosis of MS, we obviously create a differential diagnosis. What are some of the big disorders that can mimic MS and might lead to an incorrect diagnosis when the person told they have MS, but they actually don't have it?
We need to make a lot of times people are sent to us with abnormal MRI, and because radiologists read as possible MS. So sometimes brain lesions can happen in people who have migraines. They can happen in people who have high blood pressure, diabetes, high cholesterol. These are called like small vessel disease. Sometimes these lesions can look like MS, so you need the whole picture, like information, exam, and all the clinical symptoms to see if the person fits the diagnosis. Also, infections conditions can mimic MS. For example, in Lyme disease, there can be certain white spots in the area in the brain too. Also, vasculitis like lupus or any like autoimmune disease can also create white spots in the brain, and that's why when we are trying to diagnose MS, we look for the markers of lupus or rheumatoid arthritis and for any other autoimmune condition, as well as infection condition. For example, like we test people for HIV, for the other viruses.
Yeah, I think it's important to do a robust diagnostic workup. I do mention to people that you're not supposed to use a brain MRI above age 50 as a linchpin, a key feature to make a diagnosis of MS, because you start to commonly get lesions that are due to vascular disease issues and aging. Another thing that we've been tending to do, there are two much rarer neuroimmune disorders, but they can produce an optic neuritis like MS. They can produce a transverse myelitis like MS. And this is aquaporin 4 positive neuromyelitis optica spectrum disorder and MOG antibody disease. And they have two blood autoantibody biomarkers. And we are routinely sending them now to make sure that we capture these unusual mimickers of MS, because you really want a proper diagnosis. All right, let's move on to some treatment considerations. And Pat, what do we think about when we talk about treating MS? What are the various aspects to treating this disease?
Yes, so the very wonderful news is that we have many options. The first disease-modifying therapies for MS were not approved until the mid to late 90s. Prior to that, we had very limited treatment choices. But now we have quite a large number of medications to choose from. The goal of treatment with the disease-modifying therapies is to really ameliorate the disease, to reduce the likelihood of relapses, because the concern with a relapse is that a patient may not make a full recovery, and that's how disability can creep up on them. We want to reduce the likelihood of them developing new lesions on the brain MRI, particularly if a new lesion develops in a very sensitive area of the brain. And ultimately, we want to prevent disability. We want patients to remain as healthy and as active as they can. We also have other treatments for MS. The disease-modifying therapies, while they work quietly behind the scenes on the immune system, we have many symptomatic therapies that we can offer patients. If patients have problems with pain or bladder control or mood or fatigue, we have a lot of treatment options for them, both pharmacological as well as non-pharmacological. Things like physical therapy, occupational therapy, mindfulness meditation, etc. I also want to mention another really form of treatment which we try to encourage all of our patients to follow, and that is following a program of wellness, making sure that patients are eating well, sleeping well, maintaining a good body weight, giving up any vices that they might have, such as smoking or drinking alcohol to excess, making sure they're incorporating some form of physical exercise into their daily activities, keeping themselves cognitively engaged, keeping that expression, if you don't use it, you lose it, is true with our brain, making sure that they're having any of their other medical problems being looked after and well taken care of, whether it be high blood pressure or high cholesterol or diabetes or any other medical conditions that they might have. Following a wellness program can be just as effective as some of these treatments that we have.
Great. Nancy, I want to delve into disease-modifying therapies a little bit more. How much of a fan are you? Do you think there are patients that are too mild that don't need disease-modifying therapies? And how do you counsel patients on realistic expectations as they start a disease-modifying therapy? How do you tell them you're going to be following them, et cetera?
So, yes, disease-modifying therapies do just exactly that. They modify the disease course of MS. And the idea behind them is to try to prevent new things from happening. So try to prevent new symptoms, try to prevent new lesions. So they do not reverse symptoms that have already occurred or already accumulated, but to try to kind of improve things going forward. We have, such a large potential of possible medications available now, upwards of 20 different types of disease-modifying therapies. The initial therapies that came along, as Pat had mentioned, up to 30 years ago, were all injectable medications, and they did provide some long-term benefit. But in the last 15 years, there have been the advent of much more effective medications. Some of these medications do come along with more potential risks and side effects. So we always have to counsel a patient on their concerns about safety risks and their goals in terms of how effective they wish in terms of their medication management. So the goals or the things that we would cover in discussing these things would be the effectiveness of the medication, the safety profile of those medications, also how well these medications are tolerated. Our goal is obviously to have that patient take that medication without having significant issues in terms of lifestyle concerns or in terms of side effects. So their compliance, essentially. We want that person to take that medication.
Right. So I really think it's important to have a healthcare provider that's knowledgeable about MS, knowledgeable about the new treatments. We do have so many. The latest treatment was just approved on March 19th of this year, a brand new treatment for MS. Olga, let me turn to you. Do you see any central principles, key features of the use of disease-modifying therapy and treating MS that have been developed? what would you say are some guiding principles?
So I'm going actually to repeat some of Nancy's words that DMT, they do decrease damage to central nervous system, they decrease relapses, disability worsening, and MRI progression. They are not expected to improve symptoms or to improve quality of life, but they help to stabilize the disease, make sure it will not get worse.
Right. I also emphasize early treatment. The data really suggests there's a window of opportunity to treat. What's early treatment? Within 3 to 6 months of presenting with MS, within 3 to 6 months. So we really do try to get our patients on disease-modifying therapy pretty quickly. Pat, how often do you get MRI scans in MS individuals? Once they've been diagnosed, how often do you do MRI scans, and what do you do exactly?
Right. So there is no specific gold standard of how often an MRI should be done. As a general rule, annual brain MRIs being done for surveillance purposes is pretty typical. There might be some occasions where you might want to do it more often. Certain of the disease-modifying therapies might, as Dr. McClinsky mentioned, carry more risk. So you may want to do an MRI more frequently. Certainly if a patient is developing any new symptoms or any problems that you suspect there may be some disease activity going on, you might want to repeat an MRI. And this could include the brain or the spinal cord or both. It really depends upon what the symptoms are that the patient might be experiencing.
Great. Nancy, once you have an established patient, how often do you see them? Who would you see more frequently? Who would you say it doesn't require such frequent visits? What's the least frequent that you would do? How often do you want to follow your patients?
Yes, so this depends on several different factors. For example, someone who's newly diagnosed with MS, we would probably want to see more frequently, certainly within 6 months of their diagnosis. Also, when you're starting on medications, that may also be a reason to see someone a little more frequently, just to check in to see how they're doing in terms of side effects and their overall MS. Once someone is established on therapy and is more stable, then the length between visits can extend. However, there are some medications that may require more rigorous surveillance based on risks. So for some patients who require more surveillance, we may see them every 4 months. For the older medications, the injectable medications, we may see them less frequently, like every 6 months. Generally speaking, we would want to see you at least once per year.
Got it. Okay, Olga, Pat talked eloquently about a wellness program and the value of a wellness program. Is that real? I mean, how is following wellness going to help somebody with a central nervous system neurologic disease? Is there any rationale for that? How important do you think a wellness program is, and do you promote it to MS individuals at really the earliest time points? What would you comment about the value of a wellness program?
So yes, I do promote wellness. So for person living with MS, physical wellness involves much more than disease management. Its research does show that a healthy diet, non-smoking, physical exercise, adequate sleep and rest, and management of other medical conditions like hypertension, high cholesterol, high blood sugar, they all improve patients' overall health and actually the MS progression and lifespan. So this is very important that each patient is on a wellness program, and it's managed together with me, with the patient, and with the patient's primary care provider.
Right. This has been one of the big changes. I used years ago never to pay much attention to hypertension. Now I really key in on it because I know the increasing data that an MS patient that has hypertension is damaging their central nervous system, damaging their central nervous system reserve, and it's going to make MS worse, basically. So it becomes very important. We're going to be getting to the COVID era in just a few minutes, but the COVID era really brought telemedicine to the forefront. So I'd like to ask Pat, when is a telemedicine visit okay in MS? When do you think it can be extremely useful?
Right. So with COVID, we really had to make some changes, both in the way we delivered care and received care. And certainly at the height of the pandemic, we were really limiting in-person visits, and telemedicine became almost a necessity. There are some drawbacks to it. Obviously, you can't perform a full neurological exam. You can assess certain things, but you can't pick up subtle nuances. But telehealth really, I think, is here to stay. And I think it's been very beneficial for some of our patients. Some of our patients have transportation issues. It's very difficult for them to come into the office, so we're able to communicate that way. Certainly, if the purpose of the visit is a discussion, perhaps a patient is coming in on a sort of fact-finding mission to learn more information about a particular treatment that they might be interested in or that had been suggested at a prior visit, and they had questions, a telehealth visit is just fine. We've also had situations here on Long Island within the last month where we had an unexpected snowstorm, and we were able to switch our patients over to telemedicine so that nobody had to, go out onto the potential slippery and dangerous road conditions. So I think telemedicine can be very valuable, and I think it was born out of necessity with the pandemic, but I think it is here to stay.
Yeah, I think that's really made a phenomenal boost. Not that you want to use every visit as telemedicine, but to perhaps see very disabled patients more often, to allow counseling when people live a great distance away and it becomes a real hassle, and you can see them more often through a combination of direct in-person and telemedicine. So I really do hope that continues. Nancy, I wanted to ask you about cannabinoids. You have particular expertise in this area. What do you think it's important for MS individuals to know about the use potentially of cannabinoids in MS, and what are realistic expectations?
Yes, so we do think that cannabinoids can be helpful in certain conditions for MS. For example, spasticity or muscle tightness or spasms, a combination of THC and CBD can be helpful. And in addition to that, sometimes the neuropathic pain that can occur with MS can also be somewhat alleviated by a combination of THC and CBD. I would say the main concern I have with cannabinoids in patients with MS is that you have to be mindful of the potential risks and side effects of cannabinoids, which would include a potential change in cognitive function and potentially change your coordination and balance. And sometimes these are underlying issues that patients with MS already experience. So it's good to be aware of all of the risks and side effects of even a so-called natural substance.
Got it. Let's turn in the last couple of minutes to the COVID-19 pandemic and the COVID-19 era. And obviously, this is a really hot topic, and people are very interested in knowing what the impacts for MS individuals are. So, Olga, let me start by asking you, is somebody with MS more vulnerable to COVID-19? How would you counsel an MS individual about their risk of COVID-19 and if they got an infection, having more severe disease, et cetera? How are you currently counseling MS individuals about this?
So just having MS doesn't make you more susceptible to COVID or like to severe COVID. But certain categories of patients should be can be more susceptible potentially. For example, patients with higher disability score, men with MS, patients older than 60 years of age, patients with primary progressive MS, patients, Black or South Asian patients also. So obesity, like obese patients with MS are more susceptible to COVID and to severe COVID cases.
Yeah, and I was just listening to the American Academy of Neurology in the last couple of days, and they had presentations on COVID, including from Italy, and they kind of confirmed that having steroids in the month before coming down with COVID seemed to be a risk factor for COVID and more severe disease, which is interesting. So it just gives potentially some pause for thought with regard to not using steroids like candy in the COVID pandemic era in MS individuals. Now, obviously, another very important question is the COVID-19 vaccines. We have the two, Pfizer and Moderna, that are both messenger RNA, take 2 doses each. We have the Johnson & Johnson, the J&J, a single vaccine, which is currently on hold. Nancy, what do you tell your MS patients? How strongly do you recommend vaccinations? What do you tell them about the risks, et cetera?
Yes, so we have been recommending to our patients to receive the COVID-19 vaccine. We try to reassure them that there's no live virus included in these vaccines, so there is absolutely no risk of actually getting COVID-19 from the vaccines themselves. The risk of COVID-19 seems to far outweigh risks of the mRNA vaccines, so it's definitely recommended. One thing to keep in mind is that certain medications that we use to treat MS can potentially decrease the effectiveness of the vaccines. So in that particular case, sometimes we may want to change the timing of infusions, particularly of ocrelizumab, which is an anti-CD20 medication, to optimize the effectiveness of the vaccine. So it's always good to discuss the timing of your doses of vaccines with your neurologist to coordinate a potential change in infusion schedule. And I have had the question from patients, well, I'm on ocrelizumab, should I even bother getting the vaccine since it doesn't have as great of an effect as someone who's not on this medication? But I would say yes, because even some protection is going to be significantly better than having none.
Absolutely, and that's absolutely aligned with all of the current recommendations. Just out of interest sake, you know that the J&J vaccine is on hold because of 6 cases of thrombosis with a very, very low platelet count, and that's an unusual abnormality to see, and they believe it's the equivalent of what's been called a heparin-induced thrombocytopenia, or a low platelet count. This was described with the AstraZeneca Oxford vaccine, okay, but at much larger numbers. It led to it being put on hold. Now, this has nothing directly to do with MS, but it appears that women below the age of 50 may rarely, it's like a 1 in a million with the J&J vaccine, be at risk within days of the single dose of developing a very low platelet count with thrombosis. And it's interesting that AstraZeneca Oxford vaccine and J&J are both adenovirus vector vaccine? And is there something about the adenovirus vector vaccine that causes kind of an immune-mediated temporary issue with platelet counts? So that's something to just watch out for. I think we're going to hear at the end of this week whether the J&J is coming back and they limit it not being given to young females or not. So Pat, let me turn to you. So one question that's come up is, should we be changing how we treat MS in the COVID era? We heard that maybe anti-CD20s may make MS individuals, this immunosuppressive therapy, a little bit more vulnerable to treatment. It's not so clear with other disease-modifying therapies. Have you modified treatment of MS because of the COVID pandemic? Do you think some DMTs shouldn't be used, or do you discuss it with patients? Exactly how do you handle that in this pandemic?
Right. So I think our thinking is evolving over time. I think our thinking last year when the pandemic first started, our approach was different than it is now as we're learning new information. I think this is a discussion that really needs to be individualized and made with the patient, looking at the patient's risk factors, if they have pre-existing conditions, if they're at risk for a more severe form of COVID based on those pre-existing conditions, if their work is such that they may be in a high-risk environment, and what particular disease-modifying therapy they may be on. And having that discussion with them is really important. There's also the risk of stopping disease-modifying therapy and the MS then flaring up and patients ending up with relapses and new lesions on the MRI. So again, I think our approach has evolved over the last year. At this point, we are continuing our patients on, for the most part, on their disease-modifying therapy and not discontinuing or delaying treatment. However, this is really a conversation that needs to be had, one-on-one.
So we just have about 3 minutes left. I'm going to end and I'm going to turn to Nancy, then Olga, then Pat, just to make any general comments. The problem of cognition and MS. Untreated MS involves accumulating permanent damage to the central nervous system, including the brain. So it should be no surprise that over time, cognitive issues may be disrupted. I'd just like to hear people's comments about how they look for cognitive issues, how they interpret it. Do you do any special tests? And you can just give your bottom line, comments on what you think might be important to let people know about cognitive issues. So, Nancy, I'll start with you.
Well, so a lot of times we hear from patients themselves that they might be having some either short-term memory issues or just some general disorganization, that sort of thing. And that is actually a more common symptom than in MS than what we see with patients who have dementia syndromes. So sometimes it can be difficulty making decisions or multitasking, information processing. So sometimes we do a short memory test in the office. Also, our nurse can sometimes do something called the symbol digit modality test, which is very indicative of memory problems specifically in MS. And we can also refer patients for a full neuropsychological testing, which is a large battery of tests that looks at all different aspects of cognition. And as Pat had mentioned earlier, it's always important to address the whole well-being of the patient, because cognition can be affected often by fatigue, sleep issues, poor nutrition, lack of vitamins. So we want to address all those things individually.
Olga, do you have any comments on cognition in MS?
No, I agree with Dr. Maklinsky that a lot of times, in about 50% cognitive complaints are actually subjective and 50% they are objective. MS can lead to cognitive problems, and we usually make sure that patients have adequate sleep and they're in the wellness program. And if cognition still persists, then we send them to the neuropsychological evaluation to determine what's going on.
Absolutely. I consider that the gold standard. Pat, do you want to make any final comments on cognitive issues in MS?
Yes, so I agree with what my colleagues just said. It is a very common problem that our patients experience and can be a leading cause of disability. The patients who do come in who are complaining of cognitive difficulties are often frightened and worried that it's going to progress. I try to encourage all of my patients to remain as cognitively engaged as possible, to keep themselves cognitively active and socially engaged as well, not in isolation, doing word games and crossword puzzles. And I think also, as my colleague said, seeing if there's any underlying factors that could be contributing to cognitive difficulties, mood disorders, sleep disorders, things that fatigue may be an issue, things of that nature, and seeing if we can address those. And if we can address those, sometimes the cognitive function will improve.
Great. So our 45 minutes have flown by. I want to really thank our expert panel, Pat, Nancy, and Olga. All of us work at the Stony Brook Comprehensive MS Care Center. And I think it's really valuable to have expertise in MS. MS is a fascinating disease. There are new things that are virtually coming out on a monthly basis. And unless you really spend time to bore down, it's virtually impossible to keep up. But it's exciting. We have seen this become a treatable disease. We still have challenges with progressive MS and CNS repair, but everybody at the MS Center is happy to help if anybody wants to be seen. There are also very expert resources with the National MS Society, the Consortium of MS Centers, the MS Association of America, the MS Foundation are great sites. So I hope this was very educational. And again, thanks to our excellent cohort at the MS Center here. Thanks so much for your expertise.